You are a clinician listening to a patient describing a frustrating few months. Buttoning a shirt is taking twice as long, and twice this week their grip on a morning coffee cup suddenly gave way. This highly localized, seemingly minor loss of fine motor control is often the subtle onset of amyotrophic lateral sclerosis, or ALS. The condition operates through a specific mechanism, the progressive, selective death of motor neurons. These are the specialized nerve cells that carry the brain's instructions to voluntary muscle. As they degenerate, voluntary movement fails, one pathway at a time. A person with ALS systematically loses the ability to walk, speak, swallow, and eventually breathe. Because the disease strictly targets motor pathways, this physical collapse usually happens while the patient's sensory perception and cognitive functions remain entirely intact. Despite its severity, you cannot draw blood or order an MRI to directly confirm sporadic ALS. There is no single definitive biomarker. Instead, the diagnosis rests on your ability to correlate physical symptoms observed at the bedside with precise electrophysiological evidence proving widespread nerve death inside the muscles. This creates a difficult clinical dynamic. ALS is relentlessly fatal, with median survival measured in months to a few years. That biological urgency pushes regulators to approve treatments based on early, incomplete data out of a stated obligation to give desperately ill patients access to something that might help. Treating ALS requires navigating the precarious gap between a patient's desperate hope for time and medicine's rigorous demand for scientific proof. The definitive clinical signature of ALS is the simultaneous degeneration of two distinct populations of motor neurons. Upper motor neurons originate in the brain's motor cortex, carrying signals down the spinal cord. Lower motor neurons take those signals from the spine, connecting directly outward to muscle fibers. In ALS, both cellular cables undergo simultaneous, unrecoverable degradation. Microscopically, this collapse shares a universal signature. The protein TDP43 mislocalizes inside the degenerating neuron, forming clumps that physically obstruct the cell's RNA processing machinery. Roughly 90% of ALS cases are sporadic, presenting with no known family history. The remaining 10% are familial, driven by known genetic mutations in genes like C9orf72, SOD1, TAR-DBP, and FUS. ALS is a systemic, dual-front collapse of the voluntary movement command chain, driven by toxic intracellular protein buildup. At the bedside, the death of these two nerve pathways produces opposing physical signs. Lower motor neuron degeneration results in severe muscle weakness, muscle wasting known as atrophy, and visible involuntary twitching under the skin called fasciculations. Upper motor neuron degeneration results in increased muscle stiffness, called spasticity, exaggerated reflexes, and a positive Babinski sign, which is an abnormal upward movement of the big toe when the sole of the foot is stroked. The disease usually begins focally. In most patients, it presents as limb-onset disease, starting with a weak hand or foot drop. In the remaining cases, it begins as bulbar onset, affecting the muscles of speech and swallowing first, carrying a faster, more aggressive clinical course. Up to half of all ALS patients also develop some degree of cognitive or behavioral change, most often affecting planning, judgment, or emotional regulation. This cognitive change reflects a genuine biological overlap between ALS and frontotemporal dementia. The two conditions exist on a shared biological spectrum, closely linked to the C9orf72 gene. Regardless of where the disease starts, it spreads relentlessly to adjacent and distant body regions. When it ultimately reaches the diaphragm and the muscles of breathing, respiratory failure becomes the most common cause of death. Confirming an ALS diagnosis requires finding both upper and lower motor neuron signs in the same body region, bulbar, cervical, thoracic, or lumbosacral. To prove this widespread denervation, clinicians rely heavily on needle electromyography and nerve conduction studies. This EMG waveform displays the sharp, abnormal spontaneous spikes characteristic of active denervation. The test's true value is detecting abnormal electrical activity in clinically unaffected muscles, proving the widespread nature of the disease. Because the diagnosis is ultimately reached by exclusion, a physician must rigorously rule out conditions that mimic ALS, using blood panels to exclude B12 deficiency, thyroid disease, or multifocal motor neuropathy. They must also order MRIs of the brain and spinal cord to check for structural mimics, particularly cervical spondylotic myelopathy, a compressive spinal condition that can produce a very similar mixed pattern of weakness. Diagnosing ALS demands absolute clinical precision. The clinician is confirming a fatal trajectory by systematically proving that nothing else can explain the patient's physical decay. The French neurologist Jean-Martin Charcot published the first precise clinical and pathological description of ALS in 1869, building a framework that allowed future generations to recognize the disease. 70 years later, in 1939, baseball player Lou Gehrig delivered his famous farewell speech at Yankee Stadium, bringing the disease to global attention for the first time. A massive scientific asymmetry followed. The disease was instantly famous, but the first modestly effective drug, riluzole, would not arrive for another 56 years. Today, modern pharmacological management relies on disease-modifying therapies like riluzole and edaravone. These drugs provide only modest benefits, extending median survival by a few months or slightly slowing functional decline. Because available medications cannot halt the disease, comprehensive multidisciplinary care has a much more profound impact. Interventions like non-invasive BiPAP ventilation to support failing breathing muscles and percutaneous feeding tubes to maintain nutrition extend patient survival and improve quality of life far more than any available drug. In 2014, the Ice Bucket Challenge altered the pace of ALS science. This social media phenomenon converted viral awareness into over $220 million for research worldwide in just a matter of weeks. That crowdsourced money directly financed the large-scale genetic sequencing required to discover NEC1 as a major ALS-associated gene in 2016. Alongside this influx of funding is a modern regulatory environment where the FDA frequently uses accelerated approval pathways. Regulators grant approval for drugs based on incomplete Phase 2 data out of an obligation to desperately ill patients. That dynamic played out publicly with the drug Relyvrio. After intense patient advocacy, it received accelerated FDA approval in 2022. Just 18 months later, the manufacturer voluntarily pulled it from the market after a larger Phase 3 confirmatory trial completely failed to show any benefit over placebo. Relyvrio's withdrawal highlights a difficult regulatory system working exactly as designed. It balanced the immediate, desperate hope of patients against the eventual, necessary demand for hard clinical proof. The field is currently testing this framework again with tofersen, approved in 2023 as the first-ever gene-targeted therapy for the small subset of ALS patients with SOD1 mutations. Tofersen's accelerated approval rests strictly on its ability to lower a blood biomarker of nerve damage. The real-world proof of whether it actually improves a patient's strength or extends survival is still entirely pending. Which brings us back to the clinicians sitting at the bedside, delivering the diagnosis and discussing these exact treatments with a newly diagnosed patient. Managing ALS today means wielding a toolkit caught directly in the tension between hope and proof. It is a reality that traces all the way back to a ball player who stood in front of 60,000 people and called himself lucky, even when medicine had nothing left to offer him.